Good afternoon, everyone. My name is Morgan Reinig from the New England QIN-QIO, and I'll be moderating today's webinar. Thank you for joining us for the fifth webinar in the series for the New England Home Health Collaborative. This session is improving patient engagement. Before we get started, I'm going to quickly review a few housekeeping items. This webinar will be recorded and available within a few business days on our website. I'll provide you with details on accessing the recording at the end of the webinar. Phone lines are on mute for the duration of the presentation, and we will be taking questions at the end, and I will provide you with instructions on how to unmute your line at that time. Now I would like to introduce today's speaker. Rita Grimes is filling in for Kathy today. Rita is a project manager for the Home Health Consulting Division of the New England QIN-QIO, so please welcome Rita.
Thank you, Morgan. Hello, everybody out there. I'm very happy to be with you and continue this discussion on patient engagement. We're really going to sort of cover two different areas here. We're going to talk about engaging staff because we know the way that we engage patients is through our staff. So this is really going to give you some higher level tips on how to do that. Just a few housekeeping tips again. Hold on. Okay, good. Thank you. Just a review for everyone. This program is being brought to you by the New England Quality Innovative Network, Quality Improvement Organization. And you'll recall last year that CMS modified the existing state QIO programs and created multi-state regions. We essentially went from 53 QIOs down to 14 QIN-QIO companies or contracts. So in New England, we cover 6 states, and that is health-centric advisors, cover the Mass, Maine, and Rhode Island states, and Qualidine focuses in Connecticut, New Hampshire, and Vermont. So it's a great partnership, and we teach and learn from everyone here. So I would invite you to please visit the New England QIN-QIO website, and there is the address. You will get in and check out many resources for you. Please click on For Providers, and you will see the Home Care drop-down. And from there, you've got many options here, updates on webinars and many materials available to you. So if you haven't done so already, please go ahead and check us out. So we have providers from all over New England states, and I just thought that we'd show again your contacts. So anyone, for example, with any questions or needing any assistance whatsoever, you would contact Kathy Roby on the address listed there, and on it goes, for Maine, New Hampshire, Rhode Island, Mass, and Vermont. Do not hesitate. Please contact us if you're having any difficulty, either with the website or you have any questions about any aspect of patient engagement or this initiative. So why this topic, staff engagement? Like I said, staff engagement will result in better patient engagement. If we were able to achieve improvement in the measures described in this initiative, we absolutely must engage staff and get a good level of commitment from them. And in order to do so, we absolutely need to recognize the skills and ability of clinicians that are working with patients. And I will tell you that I have been teaching chronic care management for the better part of 3 years now. And critical to any classroom, whether it's you're teaching staff or you're teaching patients, you really need to understand what's important to them, what they need to know, and spend time getting a good background on, what their particular situation is and what they hope to gain from taking on an initiative such as the cardio. So I'd like to just share my experiences with both patients and with teaching and engaging staff in a project like this, chronic care management. And as we move through these slides, what I'd like you to do, if you've started your initiative, is to just sort of check back on your own process and identify any opportunities to either revisit something or to improve anything that you've already started. So I'd like to do a little polling question here and just ask all of you, step up to your computer and answer this question. Who is driving this initiative at your organization? Now, the options are QI staff. You can include in there an educator, clinical supervisor, senior manager, clinician. Perhaps you have someone very close in the field driving this initiative, or any other than that, or do you not have someone really driving the initiative? So what I'd ask you to do is just make a selection there and hit the submit button. So we'll take a few minutes to do that. Okay, so thank you for stepping up here. It looks like in most agencies it's the QI staff who are driving the initiative, and then subsequent to that we have a few senior managers driving the initiative. That's good to know. In fact, what is really key here is not so much who drives it, but that they have access to staff at all levels, and that they have the ability to teach and sometimes even more importantly to facilitate discussions and collaboration among staff members. Okay. So given that, I've put together just a few sort of considerations for you as you move through this process of staff engagement, patient engagement. We're going to go over each, but I just wanted to briefly give you an overview of the principles that have led successful implementation at organizations and with teams and with patients. And you'll see on your screen, it ends with engagement of staff members and patients, making sure the right people in the classroom when staff and patients are ready to learn, exchanging the right information, offering advice, facilitating a discussion, and allowing that discussion to happen in many different ways. So honoring the process of learning, and then to sit back and really discover where some of the issues may lie and eventually obstruct further progress there. So let's just take a moment and go through all of those steps. Preliminary to any engagement, we need to really discover what the expectations are. We flipped around medical care, and rather than asking what the matter is, we now ask the patient what matters to them. And that's as important with persons or patients as it is with staff. What do they expect to happen as a result of changing the way that we might approach care? I've heard many responses to that range from, well, I know this is supposed to work to help reduce rehospitalization rates, to somebody told me to come and sit here, or my husband told me to come and sit here and listen to what you have to say because it's supposed to be good. Now, if you ever heard similar responses to that, both would beg further exploration there to really work out, how that might happen and what that might look like. So it's important at this stage to really explore hopes and fears. What are some of the obstacles? Are the hopes realistic? Don't assume the expectation, provider or clinician expectation. And really important to secure a provider lead. Okay, so that should be someone in the organization who truly can sit through the training, preliminary to training, work through some of the obstacles, set realistic measures, and then throughout the entire process of the initiative, lead the way with staff. This will truly help to bring back and make the experience very realistic when the clinicians in the field using some of these techniques to come back and then talk about what happened, what worked, what didn't work. The next step is to construct your classroom. Really consider who are your stakeholders. We have, this has changed for me over time. Initially, I've had agencies calling me to say, come on in, we want you to train our nurses. There may be a therapist or two in there. But of late, I would say over the last year or so, the classroom looks very different. We have providers in the classroom from, acute care, case managers, outpatient departments. We have physicians. We have medical students. We have medical and social workers. We have all different therapy disciplines. We have finance people. Daycare clinics, Jocelyn Clinic is one that comes to mind. And then we have physician practices. So, the more diverse your classroom, the more engagement you'll have, and it'll be a huge payoff in the end as we move through some of these steps and some of what we were able to discover. It would be the same for patients. So, who is important to the patient? Who does the patient touch on a day-to-day basis? And once you've started engaging the patient, you can determine with that patient, is it important to have someone else present who's involved in their care or who cares to be involved. Once you've got the right stakeholders and have got their attention, essential content. What do you provide in a chronic care program or in this initiative? And I'm very happy to say there's so many different models out there for chronic care management now. It's not just patients dealing with the big four disease processes. Many more, that essentially any chronic condition, there will be a model and there will be specific interventions to assist the patient toward making choices and better health. The bulk of any program or focus in an initiative should be your self-management concept. So I know for myself, I spend at least a whole day going over motivational interviewing techniques, reviewing the theories of behavior change. What does adult learning look like, and what are some of the tools we can use? Health literacy is critical, and also just methods of working collaboratively with patients and providers. It's not just, the patient in the home any longer. It's, really across all provider types. Once you've really sort of given staff and patients the opportunity to work on some of these self-management concepts, then they're ready to hear the information about the pathophysiology of heart failure, of diabetes, of COPD and depression. It's good, I find, for staff to really review that, and that certainly is one area that probably the least amount of confidence lies is in the pathophysiology. So we do spend some time, a significant amount of time, on reviewing that, and all along you're building their confidence in being able to convey in simple terms and being able to teach the methodology there. There's always should be a component of telehealth and other technology that supports the care. This is really a standard for practice right now, and just about every program includes telehealth. What's the benefits of collecting all those data points and the value of having that biofeedback to patients? They quickly can learn, the effect of their diet on, for example, a weight gain. So salty meal the night before, now I'm up 2 to 3 pounds. So, and then of course, transition of care is critical for collaborating between providers and conveying essential information across provider types. So, I just want to say that I use the self-management concepts throughout. I begin by teaching about it, and then throughout the entire program, we teach about, we use those tools. So we use, for example, when is the nurse ready to learn a new care approach? Does that staff member have the confidence to go forward and teach the pathophysiology behind heart failure, for example, and then to facilitate and grow their confidence? Okay, so another polling question, if you all step up again, how often do you use motivational interviewing techniques with your staff? So we're talking here about using, for example, OARS, and we're going to go over that in a moment, but OARS or SMART goals have that expectation. How often do you use with staff review of self-efficacy tools and health literacy approaches? So we're going to take one moment. If you can go ahead and weigh in on that, that'd be great. Thanks. Okay, so thank you for that. We have a fairly good response here. People are using motivational interviewing techniques with staff sometimes, about the predominance of answers. Sometimes you're using it. Rarely we are weighed in with 2 out of 16 and then routinely 2 out of 16. 7 did not respond to this poll. So it's important, and I find in the classroom, when you're working with staff or when you're in case conferencing or case management meetings, it's important to constantly revisit those sorts of things. And as time goes on, you'll develop, and staff will develop greater confidence in doing that. They develop the confidence, and it becomes an easier step forward with patients and families. The next step here is to offer advice. In your teaching approach. Okay. I think we missed it. Yeah, we did. Okay. The next step here is exchange information, and I just want to say one thing. This is an area, we're talking a little bit about facilitation here. Many people are able to teach. It sometimes becomes a challenge to be able to teach and facilitate this type of learning. So I would ask that you try it out, and the more comfortable you're able to move staff towards, just sort of second nature. Well, I use doors and this is the response, or, I used a bubble chart and this is the response. The more that you're able to do that and facilitate a group discussion and group learning on it, the more comfortable staff will be. So some of these approaches we'll go over again. Case scenarios are critical, and we all have them. We come out of the field, and we've got many, many experiences on a day-to-day basis. It's good to use a case that is currently active and that someone's had a new experience with. And I know when I'm teaching staff, that we're just alive with examples. So I like to work on those and give a few challenges out to the group and say, well, go try your OARS on this patient. And next time when we come back, we'll talk about that. So case scenarios that are current and active, and then some of those motivational techniques I already started talking about. But the OARS, for people who may not understand what that is, it's your open-ended responses when you're interviewing patients, and affirmations of what that person has said, so that we can check back with that patient to determine, did we hear that patient correctly? Is that what that patient meant to say? And then just reflective listening. That's sometimes the hardest aspect of motivational interviewing, is to just sort of sit back and listen. The more often you're able to do this and the more comfortable you are with this, it will inform your practice. You'll be able to know what's important to the patient, and that will segue into development of a SMART goal for your patient, with your patient. So, a short, measurable goal that the patient does want to reach, and really engage the patient in moving towards that goal. And then, of course, your competence tools to discover how competent is the staff member to start making a change in their care practice or approach to patients. How competent is the patient in making perhaps a behavioral change? Other tools that I've used that have been effective is, I often see in records and in talking with staff what seems to be the impossible. They'll say to me, well, I'm going to teach the patient about diabetes. Believe it or not, this becomes a challenge for me to understand how you could teach diabetes and they could verbalize understanding, and and we could drop that measure in 1 to 2 sittings. There's so many aspects of diabetes that you really want to use a bubble chart to chunk down that information and really work with the patient to say, what aspect of this, what do you need to know immediately, and then help them to break that down into small pieces of information that they can take in relatively easily. And then, of course, your teach-back methods. Teach-back is really checking back with the patient to say, we talked about this last week, and I just want to check back with you to see how effective I was in conveying this information to you. So can you tell me what we talked about? That type of a thing. Now, I've added pre- and post-test here, and specifically for clinicians. I find that if you're able to pre-test on some of the stuff, deliver the information, and then get back to post-test, that staff really, it may send a bit of trepidation through them, but they basically are very alert, much more alert and curious and engaged when you use pre- and post-test. The next step would be just to offer advice. And here I want to say both for clinicians and for teachers in the group, you know, for the most part, you will be a content expert, but you won't always be. So the predominance of time, you're going to present the information and you're going to provide the right answers. In those situations where you're not able to do that for whatever reason, it's important to fall back into a facilitation role. And so when you can't provide the right answers, then you're going to provoke the right questions, and then facilitate a change an exchange amongst clinicians. This is really, you know, our clinicians have so much knowledge, and if you provide the correct environment, they often are able to come up with the correct answer to many, many things. It also builds their confidence. And then, you know, honor that process, which is really, you know, the whole telling and teaching process, deciding what type of outcome you want to see, and it should be small and measurable. What is the goal of today's session, or what is the goal of the next 15 minutes, whether you're talking with patients, families, or with staff members? And facilitating an exchange. I can't emphasize enough how critical collaboration is. And, you know, when you look out, if you have had a multidisciplinary provider team teaching situation, it's just amazing what happens when you're able to really facilitate collaboration. Everybody learns, everybody teaches. When you're dealing with staff, and also sometimes with patients and patients' families, you know, everybody comes from different backgrounds, and they have different experiences. So don't always understand the information the same way or readily. It's up to you to determine, do we stop this session where we're at and explore that issue that's coming up, or do we park it and then follow up later? So just some really basic principles about that. Of course, your role really is to facilitate. And what I mean by that is your role here is to build the confidence of your staff, build the confidence of your patients. So it's important, again, to begin with that question, what's important to the person or to the staff member? What do they know? What have their experiences been? And you can quickly get at that using the OARS approach to interviewing. Then you would introduce some experience to the group or to the patient to build their confidence. Give them time and give yourself time to chunk down the information, come back, give it some time, let them chew on it and think about that information and test it out, and then come back and check to see what the result was there. Always have readily available, and clinicians should have some of these tools in their bags, and patients should definitely have access to some of the reference points when we talk about confidence scales, readiness to learn scales. And then case scenarios, and I like using this with patients as well, you know, what if situations, and sort of helping them to forward think, the same with staff. And then just one word, if you're teaching a group of staff members, you really want to be timely and put some sort of pressure to complete a pre-test on time and then a post-test on time. You don't want to let that go too long or the moment is lost, so to speak. This is perhaps, allowing for discovery is perhaps the greatest benefit of having a diverse group of providers in the room. I will tell you always, in all classrooms that I've been in, there are discrepancies that come up, and this is an excellent opportunity to identify discrepancies and carry forward the training to the next level with routine meetings to iron out some of the inconsistencies. So we've discovered that many providers message differently about a particular disease process. So, for example, perhaps the home care nurses eat fewer carbs, and then they go to the physician or another provider, and they say, don't eat carbs. And so causing confusion in the patient in terms of what action to take. So they don't take carbs, and then, because they're confused about it, and then they end up hypoglycemic every morning, and you wonder what's going on there. Inconsistent parameter use. This is another large area of confusion for patients. And so we may have adopted some agency parameters that we're using. We don't know what the physician is basically saying to the patient or the Jocelyn Clinic is saying to the patient for parameters. It's an excellent opportunity to have providers in one room and to talk about these things and start working towards consistent parameters, consistent messaging. And then we always find inconsistencies in the materials that we're handing out to patients, that lend a great deal of confusion to the situation. Often we find that materials are at a much higher grade level than what is effective. So we often see a grade 12 rather than, a grade 4 or a grade 5. And so, we know what patients do with that information. They just push it aside if they can't understand it. And it just becomes unusable. So expect these sort of things to set you back, and important to follow up on them again. And if you can't get multi-providers in the room, then the work becomes a little bit greater. You're reaching out to physicians, clinics, et cetera, to try and iron those things out. So a polling question again. This will be the last one. So if you're getting tired of getting up and down here. If you did the training for Million Hearts Project, which staff did you include in the training? So we're asking 1 to 2 clinician disciplines. So you had a nurse, perhaps, and therapist in the room. Did you have providers from other settings? Did you have senior management staff who make many of the operational decisions for the organization? Did you have all of the above? Or have you not done the training yet? So I'm going to give you a few moments to think about that and to submit your response. Just a reminder that when you're making your selection to not forget to hit the submit button. Thank you. Okay, so it looks like the predominance of people either have no answer or have not done the training. So I'm really hopeful that some of the tips here that you're picking up will help you moving forward to ensure that you're successful here. So we've talked about, what's going to come up in the classroom, what will come up with clinicians and with patients. Once you've done your training, it's important to really sort of carry that through. And this is perhaps the most critical work moving forward. I know, like I said, I've trained multi-different providers in one classroom from, huge provider types and ACOs and whatnot. And this really then falls to the lead, whoever's leading this internally. So consideration should be given for the expectation from individual clinicians. Will this be something such as motivational interviewing, use of OARS, teach back, SMART goals? Will this be something the clinician will be measured on and included in their performance appraisals. Will you be able to offer ongoing skills training and testing? We can't just throw people to the wolves, and we know that it takes many repetitions to sort of get this stuff down. And then what will you do beyond the initial training? Will you then have all your new staff coming on in an onboarding process, go through the training program, and anyone else in the organization that should be sitting at that table? So what are your plans for follow-up and extending that teaching? Critical to have some sort of software learning, teaching, training tools, predictive modeling at the point of care is critical to facilitate, early recognition of changes in patients. So, more and more we're seeing this in the industry, that some of the more popular clinical software products will have some predictive modeling built in. And then I can't emphasize enough case conferencing. Case conferences are mini classrooms, really. I mean, I always learn a lot when I sit in on case conferencing about the patient or about the staff and just, the phenomenal job that they're doing out there. But it will give you an opportunity to reinforce some of these principles of patient engagement. And then after the training, after some of these decisions have been made, it's important to really keep that up front in everyone's mind. And one good way of doing that is through storyboards or a similar type of approach. I know staff, if we're posting a patient story, so to speak, what was the situation? What did we find? What did we do? What worked? What didn't work? You find staff approaching the board and checking back almost like, a mini-series here. What happened and with this patient and what was the ultimate outcome? So consider that. It can be on whatever scale you are comfortable with. And then I would encourage you to use your CASPER system to pull off reports that will better inform you about the specific patient characteristics and, what led to their rehospitalization, for example, or emergent care use. Also, there are many audits out there, and I would encourage you to look specifically and locate specifically within your record where you would like the clinician to document those self-management behaviors that we need to see as we progress through with our teaching. So where in the record will this information be kept? And then to do some focused audits to say what was the response to teaching and what was, are we documenting to, and can we see that the patient is adopting some of these self-management behaviors. Okay, so if you have not registered for the HCS-D cardiovascular initiative, please do so. You would be contacting your representative within your state if you need assistance with that. And just simply you need to select which measures you're going to look at. And the measures are really manageable. They're not hugely detailed. And identify the project for your staff, your agency goals, and how data will be collected. And I know every session that we do offer some tips on that to include the HCQI literature and admission packet, so it's readily available to the clinician. Insert the data collection tool in the chart for staff to begin to use on admission, and of course we're looking at outcomes, so to be completed on discharge as well. And then, on completion to enter that data into the system. I know many agencies are doing this if you haven't started already, and it's pretty much a simple procedure. Million Hearts campaign. Make it very visible in your organization. Definitely, put up signs, posters. There's many things available to you on the website. Hold a cardiovascular risk, clinic, if you will, for staff, and talk about med compliance and how to look at that and how to teach about down and dirty ways about teaching about medications in really simple language. Your agency may want to sponsor an exercise noontime walk. I know many agencies do that. And then, or support a weight loss aid, so whether that's through exercise or with just awareness of better dietary choices. One of the major initiatives through this whole QIN-QIO, HCS-D project is to hear from all of you. So to improve outcomes of patients' care within the episode, what are you doing? I mean, we throw out some ideas here, but you all work it every day, and this is a good forum for an exchange. Share your processes, your ideas, your suggestions, as well as what didn't work. You don't know who's on the other end, and who can assist you with that. We're also going to ask, we'll have some Q&A at the end and just a couple more slides, and we would ask you to type in any questions into the chat box as we proceed here with the next slide. So, we find that people really do learn from each other and teach each other. The HCS Cardio LAN is held every Thursday. There's an educational webinar offered. The next one is Thursday, June 18th at 2 p.m. So if you're available, please do join the HCS website. So at this point, I would ask that if you have any questions, please type them in.
You can also press *6 on your phone to unmute your line and ask a question. Are there any questions out there? Again, it is *6 to unmute your line. Well, if we don't have any questions, I want to say thank you to Rita for this wonderful presentation today. We do have a few more announcements before we close out. When you close the webinar today, you will be directed immediately to our brief evaluation. If you have time now, please fill that out. If not, we will be sending out a thank you email tomorrow and also include the link to that evaluation. Also in the email tomorrow, we will include the link to our website where you'll be able to find the presentation recording and the transcript of this webinar. They will be uploaded within a few business days. Our next webinar is on July 8th, and will be like a progress update on how your data looks, things like that, and Kathy may actually be back for that one, so we'll see. But thank you for attending, and we'll talk to you next month.
Thank you, everybody.